Welcome everyone to the 2021 Head and Neck Cancer Survivorship Symposium hosted by the Head and Neck Cancer Alliance and the American Head and Neck Society. Our session today is laryngectomy. My name is Dr. Danielle MacNeil. I'm an assistant professor of otolaryngology head and neck surgery at Western University and London Health Sciences Centre in London, Ontario, Canada, and I will be moderating for the webinar today. I would like to thank Dr. Danielle Deschler and Heather Starmer, along with John Reddy, for taking part in this webinar discussion. To begin, I'd like to provide some introductions. Dr. Deschler is the Vice Chair for Academic Affairs for the Department of Otolaryngology, Head and Neck Surgery at the Massachusetts Eye and Ear Infirmary. His clinical interests cover the breadth of head and neck oncologic and reconstructive surgery, including advanced malignancies of the upper aerodigestive tract, salivary gland diseases, microvascular reconstruction, and general head and neck reconstruction. Heather Starmer is a clinical associate professor in the Department of Otolaryngology, Head and Neck Surgery at Stanford University, and the director of the Head and Neck Speech and Swallowing Rehabilitation Center at the Stanford Cancer Center. Professor Starmer specializes in the evaluation and rehabilitation of communication and swallowing disorders associated with head and neck cancer. She has worked with patients following total laryngectomy for 20 years. And John Reddy is currently the president of Get Voicing, a support foundation for voice restoration, which bridges the clinical side with outreach services for laryngectomy patients and their caregivers. On September 20th, 1996, at the age of 41, John had a primary puncture and secondary placement. His 4 children at the time of surgery were 12, 8, 27 months, and 15 months old. For the past 25 years, John has served as a patient advocate, lecturing at schools, colleges, and various conferences, as well as providing educational materials and outreach services through getvoicing.org. For today's laryngectomy webinar, each of the presenters has compiled a list of questions each believe will be meaningful to other patients, survivors, and their loved ones. The initial 30 minutes of discussion will be the panelists addressing the questions between each other in a more conversational style. At the 30-minute mark of the webinar, we will then open it up for the webinar registrants in a Q&A session. So you're welcome to ask questions either by the chat or the waved hand function at the 30-minute mark or throughout the Q&A. The waved hand function is at the bottom of your screen, and in some screens, it could be under the reactions button. I'd like to really, again, encourage everyone to ask questions. The more questions, the better. And we'll start it off by having John give his experience of being a survivor of head and neck cancer.
Welcome, everybody. So just a brief little note, I happen to be in Northern California, and right now I'm reasonably close to the Dixie fire, which has really impacted air quality. So I'm doing the best I can under the circumstances. It's a little nasty outside. With that said, my journey in 25 years as a survivor was probably more just, you gotta get going. I had a great surgery team, lots of counseling in the beginning, but it's really, you gotta live every day. When you're trying to find that new normal. So with that said, I'm really interested in addressing the questions from Dan and Heather.
John, thank you very much. Let's go back a little bit, right? To the mid-90s when you were facing this decision and then you decided to go through with it. One of the questions that I face as a practitioner and we all face is, are we telling our patients enough beforehand? And I invariably feel that perhaps I'm not. But then another part of me says that, like, how much can you tell someone? Where's the information overload? And can you really be told enough to prepare you for such a seminal life change? What are your thoughts there?
That's a great question. In my case, I was diagnosed on September 5th and had surgery 15 days later. So there was not a lot of choice on my part.
Right.
At least I didn't feel like it. But what you brought up regarding information, I had, I think, excellent counseling multiple times about the plan or potential outcomes. We could go this way, that way. This is what we're going to try to do. But I can tell you my experience is almost everything said tended to go right over my head. And not because I'm not well intelligent. My children will argue that they're not here, so it's okay. It's hard to grasp when you're told you have cancer. So the fact that I had multiple discussions with the medical team, Dr. Singer, Dr. Gress, that I think helped because it's the repetitiveness of
Right.
it. And then I think, again, you what I was saying earlier about you have to just get on with the day, whatever that day is. Because it starts to then click in the back of your mind, oh, that's what they meant. That's what they said. But the look on our face, you know, if I'm sitting with you, Dan, and you tell me I have cancer, I'm going to look kind of lost.
Right, right.
Heather's going to say the same thing, and we're going to do this. And I'm going to look at her kind of lost. But every time we get together, there's a little bit more comprehension on my part of what either is pending or what I've been through. Going into surgery, I wasn't trying to figure out a lot of detail. I was trying to be prepared emotionally to be the best patient on the table that I could be for the doctor actually doing the surgery.
Dr. Starmer,
I was just going to ask a follow-up question real quick, Dan. Is that okay?
I'm going to ask you, Heather. Okay. So I'm going to ask you how you know, along that theme, how you've evolved your presentation style to patients, and your agenda of information giving. You know, what you found works, what you found doesn't work. And that'll give John a break from talking, and then your air quality may be a little better, you know, inland there. So
yeah, we're still pretty good with our air quality here. So yeah, I think it's a really good question, and I think it's such an important thing that all of us have to be thinking about. And you know, one of the challenges that we run into at some centers, like at Stanford, is patients come from such a distance for their care, and so we're always trying to optimize getting as much done in one visit as possible. But as John said, if John goes to see you and you say you have cancer, and then I come in the room and talk to him for an hour, that's probably an hour wasted because he's probably not hearing what I'm saying. And so there's sort of this challenge of how do we optimize when to give the information and how much to give. And I really think over time, what I've learned is I really have to read the patient and read the family and ask sort of follow-up questions to see how much they're gaining from what I'm giving them, because I have a huge laundry list of things I want to talk about, right? I want to talk about the changes in anatomy, and I want to talk about how that changes things like breathing and speaking and swallowing. And I want to talk about how do we protect the airway and safety issues and all of these things. But for most people, that's too much in one session. And so it's sort of parsing it out and getting a sense of when you've gotten to the point of saturation, and then sort of taking a break and trying to revisit, like John says, and working with our inpatient team so they know when the patient wakes up after surgery, that the inpatient team then can know where we sort of left off and reinforce what we've already talked about, and then again start parsing out more information. So I really think it comes down to really that back and forth with the patient, not just going in and saying, I have to cover all of this today, but saying, I'm going to cover as much as the patient is ready for me to cover today, and then let them know, you know, we're going to come back to this again. We're going to talk about this again.
I think that that's a really great approach. You know, I was very fortunate in my training to train with really wonderful clinicians like Mark Singer and Rick Hayden and Roger Bowles and such. And, you know, one thing that I've adopted to address this is when I begin the discussion, I tell them in very simple terms, you know, that you have a bad thing and it's unfair that you have this, and it's going to be life-changing. But this is a curable thing, and we're going to do everything we can to cure you and give you the best quality and duration of life afterwards. And then I'll go into all the details and I'll tell them, you don't need to remember all this. The only thing I'm going to quiz you about is what we talked about just a second ago. And then I'll go over all those things I need to go over with them. But then as we're wrapping up and we're moving on to the next thing, I pause. And I said, what's the most important thing that I've said today? And then either the spouse or the patient will say, it's curable, or I'm going to be okay. And then I say, yeah, you know, this is what, you know, we're here. And I'm here to shepherd you through all the details and the nuances and to go over them and reiterate and things like that. But the most important thing today is that we're going to engage a plan with a group of providers who are committed to helping you survive this challenge and have the best life possible. And
I think that is so critical. I can tell you there's a gentleman who, you know, it's still, I think about him every day, in that he went somewhere else and he was told, you have a terrible cancer. We're going to take out your voice box. You're never going to talk again. You're never going to eat again. And you're never going to be able to work again. And thankfully, he chose to get a second opinion. And he has done absolutely marvelously since that time. But I think you're absolutely right that that driving message has to be really key.
Yeah. Just to touch on that, you know, I have many patients that ask about meeting other patients. Because, you know, especially a laryngectomy is one of those things that if you've never known anyone that's had a laryngectomy, they just can't imagine how their quality of life could be okay after such a big surgery. What are your thoughts on that, patients meeting other patients, especially before surgery?
What about it, John?
Yeah, I mean, that made a lot of difference for me with the person I met before my surgery. And Dave and his wife are still close friends. But that's pretty much what I've done for 25 years. Is I make it a point to try to meet people pre-op and post-op. And I do a lot of that now on Zoom for hospitals all over the place, where you take all the information that Dan and Heather have talked about, which is critical and so important. And I think that patient peer visit piece kind of is the glue that pulls it all together. So they hear the clinical, the medical, and then they see somebody who's talking, whatever method. Maybe it's back at work, maybe living life, riding a motorcycle, or friends of mine who fly airplanes, and just getting on with it. That, I think, was what makes the patient a better one for when people like Dan are doing surgeries. That helps them. They're better laying there because they're more prepared emotionally. Physically, this isn't a big deal. Physically, it's a really big deal emotionally.
Right. Well, you know, Danielle, it's a great question, but it's a little bit out of our hands right now. You know, it used to be that it was critical for us to be proactive in this setting and set people up. But now, you know, you want to meet a laryngectomy, you push a button, and people can meet laryngectomies, you know, on YouTube and see, you know, things all across the board. So I think there's a good and a bad to that, because, you know, on the internet are good experiences and bad experiences. And so I think it's important for us to remember that people have access to the laryngectomy population in a way that, at least when I trained, we didn't. So these visits are very important. I do think sometimes they can be overwhelming, though, and I always am very considerate of that. I don't know what you found, Heather or Danielle, in your practices, that it can, some people are really ready for it, like you or John, but other folks they just shut down, and that, that's that point you got to, Heather, about reading the patient. And so how do you make the choice on that?
Yeah, I think it really comes down to having an open conversation with the patient, asking them if they want to meet with somebody. Right. And oftentimes before surgery, they'll say, I'm not ready. And then I'll turn to the spouse and say, would you like to meet either with a patient or a spouse who's been through this? And so sometimes providing that caregiver, spouse, or whoever it is, with that opportunity before surgery provides a little bit more support, even if the patient isn't ready. And oftentimes if they are not ready prior to surgery, after surgery, then they become more interested. And so I really think we have to, let the patient decide what they're ready for. And like I said, also try to help the caregivers. And, John, I know you do a ton of this, and, thankfully you've spoken with a number of my patients as well. I wonder if there's any sort of key theme or type of information that you feel like either you wish you had had, or you hear from other people that they wish they had had prior to surgery, that we on the medical side might be missing?
Great question, because to me, regardless if a patient says, no, I'm not ready, their experience of actually meeting a laryngectomy, either pre or post, changes their whole perspective. So I agree, you don't want to force it. But in my experience, the number of people I've visited post-surgery who didn't want any part of a visit were very thankful, and family was very thankful, because there's just no way in a normal upbringing, a reasonable person not in the medical related industry has any idea what a total laryngectomy is, and that you can actually survive without a voice box. Everybody thinks that's how you talk. And it's got nothing to do with that. In reality, because I don't have one and I'm talking to you guys. So it's understanding and perception. So it's just, I think for you guys, it's just another good tool to help support a patient. If they say no, then fine, you wait. Same thing with support groups. Prior to the pandemic, when we could meet in person, a lot of new laryngectomies would tell the story of, I don't want to attend that. They were offered to go before surgery. Kind of meet the community you're about to join. No, I don't want part of it. And then they come to the first meeting and they're like, oh, I wish I had. Because they're asking just general, like, hey, how do you take a shower post-surgery? How do you shave? How long does it take to get that routine? All these really just basic questions anybody would have. So it is real helpful.
John, if we could then let's move forward a little bit now. We always, as oncologic surgeons and caregivers, will set up the 5-year mark as a demarcation mark that you beat your disease. You're now cured of your disease. And I think that is, and it's valid and it's important. But, as a long-term survivor, what is the biggest challenge that you faced in what I would say the middle years of survival, right? So you've gotten through the treatments, you've found your new normal, you've established your new life, you now got to that anniversary, you're considered cured, you fall into more of a once-a-year surveillance or not at all being seen by your doctors, depending on the practice. I'm a little old-fashioned. I hang on to people, very desperately, and I follow them, forever, and which I find is helpful for both of us. So in that middle phase, what are the biggest challenges of that phase, do you find?
That's a great question, because I think that's the point when many of us realize that we occasionally forget that we're a laryngectomy. And that, unless we're talking to somebody or looking in the mirror, we might forget. I had a laryngectomy friend of mine years ago tell me, before surgery, every morning he got up, walked out the bedroom doors, jumped in the pool and swam laps. Becomes a laryngectomy, puts a stop on that activity. But about 10 years post-surgery, he said, I woke up one morning, opened the doors, jumped in the air going for the pool, and then he realized, oh, I'm a laryngectomy. Occludes the stoma, gets out of the pool. It's like, oh my, totally forgot. I have had those moments. I think that's in that middle range where you have those moments more often than you would suspect. They're not bad, it's just you kind of forget.
Okay. Heather, how about you? What have you felt in caring for patients in that window?
Yeah, I think that it depends, I can think about, a few years back versus now, and there are certainly some different challenges in people who've had not just laryngectomy, but also radiation and chemotherapy. But it seems to me that in that sort of middle stage, swallowing tends to become a more prevalent concern for many of my patients. Once they've gotten their communication set and they've sort of adjusted to being a laryngectomy and the breathing and the sort of critical things, then all of a sudden they start to notice, okay, I'm not swallowing as normally as I used to be. So I find a lot of my patients really start to become more aware, tuned into the fact that they're having trouble swallowing, and they want more help on that since they've kind of gotten through some of those other issues. And I think that's a really important thing for us as a team to really acknowledge. And I don't know, John, if you personally had any of those sorts of issues, or Dan, what your thoughts are about managing dysphagia in patients after laryngectomy.
Mm-hmm.
I think a point that you bring up is a great one, because they'll get over the biggest hump, which is the voice, and then the swallowing can become more of one. What I found is that in these long-term relationships and people I see 10 years, 15 years afterwards, it's the integration of the natural aging process overlaid on the assault that is the treatment of laryngeal cancer. And so you kind of get through all that and find this new normal, and you're cured. And then, like, wait a minute, I'm 10 years older than I was, right? And so now my neck is a little more forward, naturally because of aging, but then I had those muscles affected and it's more so. And, my digits and my shoulders don't get me here as easy as they used to. And, my mucous membranes, which were hit with radiation therapy, seem to be drier. And all these, my vision is not as great. I miss miss cleaning the prosthesis, and, really kind of validating that that's okay. I kind of look at those as small victories, in the sense of, like, you wouldn't be noticing your vision's a little off if you hadn't actually survived this disease the way you had. But I think that's a hard part of it, because aging is harder after you've been through this.
Any sort of interventions? Oh, sorry, I didn't mean to interrupt, John. I was just going to ask about interventions or anything that's helpful for swallowing.
I was just going to comment on the swallow. I dealt with those issues post-surgery, just I think as a natural. Noticed it was a little bit different, learned techniques to address it, smaller bites, chewing more thoroughly. All the things our mothers told us growing up we never did. And then my question or my comment to Dan on that is, I thought that by going through the surgery, you guys would have figured out a way to address that aging thing. I didn't have to do both.
Yeah.
I don't think that's fair, personally.
Yeah. It was very lame of us as a profession.
But you're right. This is the thing I'm noticing as I'm 25 years older. And some of the things I'm experiencing, like this air quality was not an issue even 3 years ago for me, but I'm reacting very differently. I'm still doing, I drink a ton of water to stay hydrated, but it's just my body's not what it used to be. So work on that, research that one for us, Dan. We need that.
I'll get on that. I have one more question, which, you know, I'm going to fit into the thing that's been dominating our lives for the last 18 months. Did you feel more marginalized by the COVID epidemic? Did you feel that it put you at a particular disadvantage, you know, amongst the entire world that was, you know, also suffering through this?
In my case, no. I became very concerned for laryngectomy. And one of the things, and you guys know the stuff I do, I work with you guys, respiratory therapists, all kinds of stuff. So I have a different understanding of what goes on with me. I know the importance of managing my airway in the normal course of things. So I saw the threat of the pandemic in the sense that as long as I social distance and wore a mask, mostly for the social stigma of not wearing one at the time, that if I manage my airway and protect it by wearing an HME, a micron if I'm out in public, that pretty much reduced my risk. And so I tried to share those general things. But my concern was for people who are recent laryngectomies who may not know all the importance of the respiratory aspects of being a laryngectomy and the changes. And anybody that was having surgery during the pandemic, they're now alone, even families not coming into it. So I was part of an article that was published by a neck journal on this issue of the impact of COVID on quality of life and, you know, support groups and things like that. It had a big impact.
How about you, Heather? What are your thoughts in this, you know, over the last 18 months?
Yeah, I think, you know, it has become, you know, in some ways things have become easier. So, you know, if I had a patient who lived very rural and I wanted to connect them with John, we've learned how to do that through Zoom. So those are the silver linings. But I agree with John. I think our patients who went through surgery during this time woke up in a hospital room without an advocate by their bedside, went through their entire hospitalization without somebody that they know sitting next to them and helping communicate for them. And I think that has probably been one of, you know, the hardest things for our entire community to try to deal with during this time. It's also, there have been times where, you know, early in the pandemic, we were trying to keep everybody out of the clinic, right? So how do we handle changing TEPs? You know, there was a period of time where we just sent everybody plugs and said, you know, let us know when this no longer works for you. And then came the question of, you know, how do we make sure that they're safe and they've got their stomas covered, and making sure that they're using appropriate filtration, and what is appropriate filtration, and should we be testing them differently? Should we be testing them through the stoma? So I think there were just so many questions that we really didn't have answers to, that made it really challenging to try to protect these individuals, particularly those who either are, you know, have less health literacy, less advocacy with caregivers, or newer to the game. You know, John has been doing this for a long time. He really understands that respiratory piece, but my patient who maybe had their laryngectomy 6 months ago, there's just so much information that they may not have. So I think it has been really challenging over the past 18 months to ensure our patients are having appropriate care and social support as well.
Yeah, no, I think that you've done a stalwart job with that, but I think it's a population that was particularly at risk. And, you know, I think that, you know, what you're hearing is that the efforts of the people who have gone through this, such as John, and the advocates such as that, and the speech therapy advocacy is so critical to us having gotten through this. And I think everyone did great work with that.
Mm-hmm. Good that we're hopefully seeing a little bit at the light at the end of the tunnel. Yeah. But yeah, I'd like to go to some of the questions if you are all okay with that. So one of the first questions was from somebody who was a veterinary surgeon, so had a little bit more experience in terms of medicine and surgery, and just had a question about being on track, where they felt that they weren't really on track because the expectations for recovery were longer than what they expected. So they expected to be back to usual functioning at 6 months, and it took more like a year. And with respect to, laryngectomy in particular, a question for all of you: when patients kind of fail with the voice prosthesis and managing those feelings, of failure if they can't use a TEP.
Well, I think the question about being on track is a challenging one, right? Because everybody's journey is going to be so different. And the expectations for somebody who's had a primary laryngectomy is very different than the expectations for somebody who had radiation chemotherapy and then had to have a laryngectomy, or for somebody who has a laryngectomy because they have such severe swallowing problems that they need to have separation of the airway and the swallowing passage. So I think the expectations are challenging, and I think it really is so individualized in terms of how people recover. And, in this particular instance, it's hard to know exactly, where the challenges were for this individual. But I think, I would love to hear from John, his perspective as a patient, but it's understandably very frustrating when you have expectations of a certain level of recovery. And perhaps we can get into more details if we hear them. But John, what are your thoughts about that? You see this a lot.
I do see it a lot. When I'm working with people, I try not to let them set expectations on what I went through. I'm supposed to translate to them. Mm-hmm. Everybody's case is different, everybody's situation. In my case, I didn't talk for 90 days. It was surgery, then radiation. So I was told, we're not going to focus on this. Let's get through radiation. Okay. But overall, for me, the motivation was get back to work. So, okay, we're going to wait, and I'm going to get through this, and we're going to start the talking thing. But that was my motivation for trying to do that as well as I can, was I needed to go back to work. And whatever somebody's motivation, if you're a golfer and you miss being out on the golf course, if that's the focus, then use that as the motivation to whatever your rehab cycle is. Do that. And I don't want to make it seem too simple, but getting through a laryngectomy, surviving it, and learning to talk or communicate again is really not difficult. It's just challenging because you really never had to do it at this level.
One thing, Danielle, I really try to do is I try to take the term failure out of the lexicon I use with patients. Like if they're going to have a swallow evaluation, it's an evaluation, not a test. It's how they're doing at a point in time. It's not a pass or a fail. Because, to face cancer and have your life threatened and then have someone remove an important part of your being that you're never going to get back, it's just so traumatizing in and of itself to then have, these tests of like, did my flap heal? Is my stoma good? Did I fail in this and that? Especially in this era where, fully a third of people will have a fistula afterwards, but the patient will feel that they somehow failed in their healing because what can I do to make this better? And again, at every turn, I try to, alleviate them of guilt on that because it's not their fault. And I actually, it's important to do it all across the team. It's important to, if you don't get voice the first run, it's not the speech pathologist's fault, okay? And I do it with the residents, and it's like, this is not your fault that this happened here, because we all take it very deeply. We want everyone to do really, really well. Feeling like you failed when you've been through all that is really, I think, really, kind of piling on. And so, I think it's important for us to try to, help everybody with their, their journey. I learn from each one that I go through with somebody something different that I try to bring to the next one.
Yeah, I think on that point, oh, sorry, go ahead.
I was just going to say that's a really important message. It's so important. Yeah.
Yeah. And I think, you know, the research shows that people are much more prone to depression and anxiety after any sort of head and neck cancer treatment, particularly laryngectomy. So I think for individuals who are struggling like this person who asked the question, I think it's really important to communicate that level of concern to the care team so that we can bring in other sorts of supports, whether it's medication or whether it's, you know, some sort of talk therapy or whether it's going to a support group. I think we have to acknowledge that sort of psychological impact of this surgery as well, which John spoke about earlier.
You know, sometimes if someone's had a fistula and we're like day, you know, 5 of managing this afterwards, and maybe the output's decreasing, you know, I'll just sit next to them and I'll just say, you know, this sucks. And just say nothing else, because, you know, it does. And it sucks for them. And then, you know, but we got to get through it. And that was really hard when I was a young caregiver, because you know, I always wanted to do what I want to fix, and you know, we're all impatient. But you know, to just sit there and then say nothing is probably one of the hardest things I do, but probably I like to think one of the most important things I do. And I feel like I'm getting better at that at the time. So.
I'd like to encourage everyone, if you want to ask a live question, to raise your hand. And we do have a question from Regina. If we could unmute them so they can ask a question.
Sorry, no question.
Oh, okay. Yeah, and just an open invitation to everyone else. I do have another question from somebody who wanted to know about the challenges surgeons face when completing a laryngectomy flap reconstruction on radiated skin, and how the complications might be different after.
I think it's so much part of what we do right now that you know, as we do the procedure, you know, as someone who does who does the removal as well as the reconstruction, I sort of built a career around, you know, having whatever tools available to fix that person with that problem at that time. And that's kind of the way, you know, we approach it, in the sense of like, okay, let's bring the best thing in to repair at this time, and give them the best chance of success. But we face a whole different era right now in dealing with tissue that's you know, at least in the States, has undergone chemoradiation therapy, which is just different tissue, and it doesn't heal as well. And I think for us, it's important. I think what's important to do is to prepare the patient more for the possibility of a prolonged healing course, and that things such as swallowing and voice may not come back as easy. But as I tell patients, you know, I say, you know, I can't change who you are and what tissues you have, you know. So I kind of say that, you know, my job isn't to deal you a new hand, but let's take the cards you've been dealt and play them in the best possible way. And that's what I try to do with, like, bringing in this piece of tissue for them, or doing this plexus neurectomy in this setting, or, you know, bringing the skin in this way. And, you know, the more you do it, the more you're able to apply, and the more you listen to people who've succeeded and failed in the past, the more you're able to apply. And that's I think that's the most wonderful thing about surgery, is that you acquire these skills to make that person better on that day.
Steve has a question, if we could unmute Steve.
Yes, when you're doing a pre-surgery patient visit, and they ask you, they said, oh, I read on Facebook, I hear all these, oh, you know, how horrible it is. You know, I really don't get into that, but what do you do when you say, tell me how bad this is going to be?
Well, again, I try to flip that a little bit. You know, I say that no one comes into my door asking for a laryngectomy, okay? They come into my door because they have this thing that's going to take their life and take them away from their loved ones. And if left alone, kill them in a way that's really unpleasant. And I always offer the option of doing nothing because I think that that's only fair. But if I offer that option, I do outline what the sequence of events that follow are. And then I really outline what the procedure is and how it's going to change them and the things we're going to try to get back to them. And, you know, usually they're there with somebody and, you know, that person in that room is not going to love them any less if they have a different anatomy. But at least they still get to love them because they're there. And those are the things I try to connect people with. Not the bad, because I can never prepare you for the, you know, the extent of the life-changing aspect of it. And that's what, you know, we talked about earlier in this. But I do want you to understand, people to understand why they're going through it. And it's the connection to, you know, the person that's with them, or the granddaughter that's going to be born in 6 months, or the wedding that's in 9 months, and those life things that, you know, keep us all going.
I think it's also really important for the patient who's been out on the internet, has been scared basically by what they've seen, is trying to bring it back to the successes again, you know, the Johns, you know, the many patients that we've had who have gone back to doing, you know, every career, and, you know, trying to balance the negative that they've seen on the internet with positive outcomes, and also, you know, acknowledging that sometimes things do not go perfectly and it takes some time to get there, but we are here as your team to get you through those hard times if you go through them, so that there's less focus on the really negative outcome and more focus on what we can do should those things happen, and that we're here to get you through it no matter how long it takes.
You know, one of the great fallacy studies ever done in medicine, I think, was the firemen study years ago, where they asked healthy firemen whether they would rather accept a lower cure rate and keep their voice box, or if they would undergo a higher cure rate and sacrifice that. And I think that it gives you a glimpse of humanity, but, you know, that's not the person who's sitting there in the office who has the life-threatening disease and who has to make that decision. And that's a far different decision in the reality in the room than it is in the theoretic. And I think that, and that's what we, you know, we traverse with people and marshal all our resources to benefit them for. But that's really hard. You know, it's really hard. And I think, you know, as Heather said, you know, looking to the successes and the Johns in the world who are out there.
I have a question from somebody that's wondering about interaction between the radiation oncologist and the surgeon. It sounds like they had 35 sessions of radiation and then later went on to have a laryngectomy. Maybe we can speak to the importance of, you know, the healthcare team, if you're able to choose the healthcare team, and how important communication is amongst not just physicians, but the entire allied health team. What was your experience like, John?
Mine was the surgery. My doctor controlled whether or not I was having radiation afterwards and where. And that was fine, because at that point I was just learning how to spell radiation, because I wasn't even going to try laryngectomy. So the point being is that I was relying on their recommendations. Looking back on it, it was the best choice given the results. Although I've been heavily radiated, it was playing the odds a little bit in that I probably didn't need it, but we know that looking back. We didn't know that at the time. And I think that's part of the struggle that, you know, Dan has when he's trying to pull his team together, is that, you know, maybe this is in this range, but maybe this is better. So you have to counsel, and Dan, you mentioned earlier, sometimes just sitting and holding a hand when things just aren't good. That kind of situation for me was always the most powerful, because it gave us the opportunity to get on the same level of what we're dealing with. You know, if I had expectations that you had a magic wand, you've now eliminated that, and not in a bad way, but in, you know, now I'm like, all right, that was probably not my best perspective. But now we're having a moment where I'm like, all right, so what are we doing? So I remember saying that to my doctor at one point, all that information coming at me. I said, listen, just remove the tumor, because I don't stand a chance unless you do that. I don't know what the rest of this all means or what's going to happen. I'm just asking, give me the shot, give me the chance to try to do something. And I think sometimes it can be that blatant or just implied.
You know, one thing I do in this modern era where people are often receiving chemoradiation prior to, as a first effort, and then most laryngectomies are done as a second procedure after that, is that usually I've met the patient and then have been involved in the multidisciplinary discussion, and then they'll go off to chemo and radiation therapy. But what I really make a point of is that to make sure that at about 4 weeks into treatment that I see them, okay? And there's really not much that I do during that visit, you know, physically and stuff. But what I tell them is that when they're all beat to hell, I want to tell them this is good, okay? This is the way you should look, all right? And I want to make sure that they're like that. And, you know, and say that, you know, as bad as you feel, you know, your tumor is doing worse, you know, because of this. It's okay to feel like hell right now. It's going to get better. And it's really, it's more of a visit to solidify the plan so that we're connected again. And as we go into follow-up, we don't have this long gap where we're not bonding as, you know, caregiver and a patient, because should we need to proceed with surgery, that the solidification of that relationship, I think, is really, really important. You know, just like it's okay that you look like this, and, you know, it'll get better.
Any comments, Heather?
No, I think absolutely. I think the role of the multidisciplinary team and the communication between the team members is just so critical to getting the best outcomes possible. And, you know, I really advocate for really having a whole team approach, because this is a challenging thing to get through, even in a good situation. And so, you know, again, getting back to really patient-centered, what are the goals of the patient? What are the challenges of the patient? And pulling in, whether it's a dietitian, whether it's a physical therapist, whether it's a lymphedema specialist, whether it's a psychological nurse, whoever it may be, you know, you really want that team approach, and the patient and the caregiver are the center of that team. They are just as important in terms of information gathering and planning as anybody on the medical team. And so I really think that open communication between everybody is really critical.
Yeah, I think it sounds like John was an amazing advocate for himself and continues to be for himself and other patients. And I think that's really, you know, something that is important when you're getting treatment, before treatment, during treatment, and then the survivorship phase, for sure, that you're a good advocate for yourself. And that's an expectation of the healthcare team, is that they're communicating amongst each other and communicating with you. And if you're not getting that as a patient, you should really be demanding it, because it's, you know, it should be patient-centered care, and the healthcare team is really here for you and working for you. So. We do another question about acid reflux due to anatomy changes, and any suggestions for coping with that.
Who wants to address that? As a patient, I can tell you that I think, one, it's very real. I think laryngectomies inherently have this condition. It's asymptomatic, so most will say, no, I don't have it. There's a variety of therapies available. You can take over the counter, proton pump inhibitors. You can get prescription. You can look at modifying diet for the things that trigger and help soothe the condition. You can do simple things like elevate the head of the bed 4 to 6 inches, because gravity is a real law, and that one helps keep things in the stomach.
Yeah, I think about a gentleman who I used to work with who was a big pool player, and he would come in and say, every time I play pool, I end up with all of this coffee in my mouth. And I said, okay, well, then we have to think about modifying your behavior then. You know, you don't want to be doing things that are compressing your stomach or bending over right after you eat, because you are definitely at risk for having that issue. Dan, how do you usually manage reflux in your patients?
I think that I address it symptomatically, you know, as John sort of spoke with, and that, you know, as you alluded to, you know, you're taking away one of the sphincters, and when you do that, it's going to be an issue. I think where we're seeing it having one of the bigger issues, though, I think is in prosthetic duration and having the effects on that, and also on, you know, the tenuous tract. You know, I think that one of the big challenges in voice restoration over the last 2 decades has really been that we now have a fistula tract that goes through a much more assaulted piece of tissue. And that's what leads to the thinning of the wall and prostheses, you know, which aren't fitting as tightly, and leakage around. Like, you know, I look at reflux as another, you know, assault on it. And, you know, the laryngectomy patient, I think, who back, 3 decades ago, who got a laryngectomy for their cancer and then got radiation therapy, they kind of, walked on a pretty wide sidewalk. And, now when you add all these things, the chemoradiation and such like that, which has been phenomenal in decreasing the number of people who have to have their voice box removed, but at a price, that sidewalk narrows, and then you can get tipped off that thing when it gets to be like the width of a beam. And a little reflux may be the thing that tips you over. And so it's one of the many things we have to pay attention to, as well as nutrition, as well as, are they hypothyroid after, having had radiation 15 years ago? And what does aging do to tissues? All these things that we talked about. So.
Yeah, I think that's a really, really important point when you mentioned the prosthesis, because, a lot of times the issue with the prosthesis is really linked back to what's going on in the esophagus. The prosthesis lives, half of the prosthesis lives in the esophagus. And whether it's acid, whether it's food that's not clearing through, whether it's dysmotility, where the food is sort of moving to and fro in the esophagus, all of those things impact the prosthesis life. And so if we're running into issues either with the puncture or with the prosthesis, we've got to make sure that we're looking at the esophagus and seeing if there is indeed a cause within the esophagus that we can maybe do something about, rather than just switching from brand to brand or type of prosthesis to type of prosthesis.
Any last comments from the panelists? No. Well, I would like to thank all of the survivors and the caregivers for your attendance. A special thanks to our panelists, Dr. Deschler, Heather Starmer, and John Reddy, especially for suffering through the poor air quality, as well as the Head and Neck Cancer Alliance and the American Head and Neck Society for their time in organizing and hosting the webinar. There were a lot of great comments about all of you, and many of the panelists, or many of the participants had personal experience with Heather and Dr. Deschler as practitioners, and also with John, and had wonderful things to say. Thank you also to our sponsors who are shown on this slide. Please participate in the poll that will be showing up on your screen at the end of the presentation. And lastly, we hope you will join us in September for a special screening of the film, Can You Hear My Voice? By Bill Brummel. After having his voice box removed in 2016, Brummel produced the film, which chronicles a London's choir whose singers are also living without voice boxes. Following the screening, a Q&A with Brummel and a medical expert will follow. More information about the webinar will be available at the Head and Neck Cancer Alliance website soon. So thank you all. It was really an honor to participate in this with all of you.